Modularity in total shoulder arthroplasty, worthwhile, overrated. The design of modern humeral component of total shoulder arthroplasty has continued to evolve since originally reported by Charles Neer in 1973. Okay. The design of modern humeral component of total shoulder arthroplasty has continued to evolve since originally reported by Neer, 1973. From there on, a plethora of implants were invented throughout these years. Why of this evolution of new designs? The bone of the proximal humeral exhibit a large variability in geometric dimension with respect to the inclination and retroversion, medial and dorsal offset. If you consider the proximal humeral part as a ball over a cylinder, why a ball or sphere? In 106 MRI studied, 90% of the humeral heads had less than 1 millimeter difference between the two extreme diameters. So the articular surface constitutes about 1/3 of this sphere. What about the relation of this sphere over the cylinder? There is a medial offset of average 6.9 millimeters between the center of the ball or the sphere and the axis of the humeral shaft. Also, there is a posterior offset between the center of the ball or the sphere and the axis of the humeral shaft. It's about 2.8 millimeters. So there is anterior and medial offset. So as we can see here, this is the axis of the shaft. The anterior part is small, posterior part is large. So the medial and posterior offsets are available. The thickness of the articular head or part of this ball or sphere ranges from 12 to 18 millimeters. And diameter of the articular head part of this sphere ranging from 36.5 to 51.7 millimeters. Also, the inclination varies. It differs between 114 and 147 degrees. Also, there is a humeral retroversion, ranging from 17.9 to 47.5 between the head and the epicondylar axis. So there is inclination, retroversion, medial offset, posterior offset, head diameter, and head thickness. So how can a monoblock prosthesis meet all of these criteria? So the first evolution between the modular heads with the second generation heads of neck in variable sizes and lengths were designed to increase the ability to match the individual anatomy, allowing for better soft tissue tensioning and component alignment. So this is correct the medial and lateral offset. A third generation of prostheses with triple head diameter and thickness and can also correct the anterior and posterior offsets. As you can see here, you can rotate the head to have anterior and posterior offsets. Then a modular and adaptable heads or prostheses. All the previous modularities plus variable inclination and retroversion prostheses with 3-component stem at neck and head. Then a convertible platforms. They can do whatever you like as regard inclination, retroversion, offsets. Very good. You can cover all of this. It's a very good job. But these fast-growing modularity options come with a price. A high cost of implant, dissociation of the posterior components, and the most important thing is a false sense of confidence of the surgeon that this modularity can correct everything, you can do it, and can balance everything. So here's the question. Does the increase in prosthetic modularity improve the results of anatomical shoulder replacement? In 2005, Sperling compared the results of unconstrained total shoulder arthroplasty for osteoarthritis. He had two different groups. Both are demographically the same. Done by the same group of expert surgeons. First group with a monoblock done between 1992 to 1995, and modular design done after 1995. And he concluded that there is no significant difference in the clinical outcome or radiological changes between the first and second generation design of implant. In 2015, Kofeld and his team repeated this study using 3 types of generation. Done by the same surgeon, Kofeld and his colleagues, compared the results of the first 3 total shoulder generations were performed for primary osteoarthritis. The 3 groups are demographically almost the same. All generations showed similar pain relief, improved range of motion, and NIRS rating. Survivorship among the 3 groups was similar at 5 years, but was estimated to be higher in the first generation, which is the monoblock. At 7 years, more glenoid component was radiologically at risk in the second and third generation group rather than the first, which did not reach significance. Doring at 2020 concluded that intraoperative assembly of the anatomical shoulder prosthesis frequently results in malalignment of the modular junction. As you can see here, it should be a long contact surface. If it is positioned malaligned between 2 contact surface or points, which leads to confusion, dissociation, and disturbance of biomechanics. Bicknell at 2021 concluded that the newer generation anatomical implant provide improved radiological anatomical recreation when controlled compared to the older generation. These new designs can keep the humeral head acromial distance, match the normal anatomy, and very good. But another study hit the target from the start. Does the impact of a prosthetic designs on a clinical and radiological outcome of total shoulder arthroplasty of a respective study that affect the clinical results and the radiological results? He said the following. Our results indicates a significant subjective and objective outcome regardless the type of implant of total shoulder arthroplasty. The near 2, which represents the older design, was associated with more radiological evidence of lucent lines and less external rotation at 90 degrees of abduction, but patient satisfaction was not affected by the radiological evidence of lucent lines or type of prosthesis. So, relying on a high prosthetic modularity as the sole guarantee to succeed in shoulder arthroplasty is not reliable. The modularity of the shoulder prosthesis will not correct soft tissue balance, will not cover for any mistake during shoulder insertion, during surgery. So the key of success is the following. You have to choose your patient correctly, do your job in preoperative planning, as mentioned in the previous lecture. Don't rely on the shoulder prosthesis to correct soft tissue tension. Don't rely to cover of any mistakes. You should do good preoperative planning, do whatever you need in radiological assessment, compared to the other side, compared to the variables in literature. And you have to correct soft tissue imbalance by yourself, by releases, muscle transfer, whatever. Don't consider for the shoulder modularity to correct the soft tissue itself. Also, the careful supervised post-operative rehabilitation is a must and should be done under supervision of the surgeon. Thank you.